Good afternoon, everyone. We will get started here shortly. If you are a committee member, if you put your name in the chat, let us know that you are here. But I think we're still waiting on Rachel to join, so we will just give it another few moments. Hey, Rachel, you are there. Thanks. Yes. Maybe just give it another minute. I'm going to do one final count. People are still joining the meeting to make sure that we have a quorum.
Hi, this is Nancy Strahan. I'm a committee member, but I can't put it in the chat because I'm driving, but I'm present.
Yeah, no problem. Thanks, Nancy, for letting me know you're here. I appreciate it. Okay, final count is good. Rachel, if you want to go ahead and kick us off. Thanks, everyone, for joining today.
Thank you. Hi, everyone. Welcome to our April MAC meeting. Thank you all for joining us on this, wherever you are, your weather is like day. The first thing I will do is take a motion to approve the minutes for March of 2025. Those were sent out to everyone, so that will be the first thing I entertain.
Colleen Kenny, I make a motion to pass the minutes from last meeting.
Sure, and does anyone want to second that?
Second, this is Jennifer Brinton.
Thank you. And then if no one disagrees, then I will consider the March minutes approved. And then we'll just go straight into some 11:15 waiver amendments public hearings. So Laura, if you want to get into those.
Great. Yes, thank you, Rachel. I am going to introduce two 11:15 waiver amendments today. They are the disability wraparound coverage and inclusion of children and pregnant postpartum women in the dental services demonstration. This meeting serves as the first public hearing of these 11:15 amendment applications that I will be summarizing today. So as usual, I will read through the document and then we'll open it up for public comment, meaning you can provide a verbal feedback today. Just a reminder, there are other means to provide feedback outside of today's meeting. They include emailing to the 11:15 waiver email address, online through the website, and then a second public hearing will be held on April 21st, so this Monday from 4 to 5. So I will drop the comment submission information in the chat, and then you can also find it on the 11:15 website. And the public hearing information is posted right now, so you can link to the comment section from the main page as well. So let me just drop that in the chat. And then I will go ahead and just read through the summary document here. So the first waiver amendment is disability wraparound coverage. This is an amendment that resulted from House Bill 310 that was run during the 2025 general session. And with this amendment, the state is requesting authority from CMS to provide wraparound Medicaid services for qualified individuals who have minimum essential healthcare coverage and have a disability. These wraparound services would cover benefits available under Medicaid, but not provided by the individual's minimum essential coverage. As far as the eligibility, individuals eligible must be disabled as described in the 41 U.S. Code section 1382C, must have been enrolled in Medicaid within the previous 12 months, must be enrolled in minimum essential healthcare coverage other than Medicaid, must not meet the income or asset requirements for enrollment in Medicaid. They must have a household income that is between 250 and 800% of the federal poverty level, and they must meet the resource requirements. The state will follow the Medicaid Work Incentive Program resource requirements that are outlined in the state plan. with the exception of the resource limit, which with the approval of this waiver will be a maximum of $125,000. Participation in the disability wraparound coverage demonstration is subject to an enrollment cap, which is based on available state funding. The state may close new enrollment in order to stay within state appropriations. As for the benefits, the qualified individuals will receive wraparound services, which includes services covered by Medicaid, but not covered by the individual's minimum essential healthcare coverage. We do intend to implement the proposed benefit as soon as possible if approved by CMS. As far as the impacts to the members, the qualified individuals must share costs that will be based on a sliding scale established by the state. Individuals with a household income greater than 400% of the FBL will be required to pay a minimum of 10% of the service costs, not to exceed $1,500 per month. Payments toward private insurance premiums will be counted toward meeting the individual's monthly cost-sharing responsibility. And the state will establish income categories, cost-sharing rules, and provide 12 months of continuous enrollment for these members. And we do expect a projected enrollment to be approximately 30 individuals. I'll go ahead and just go through the second amendment before we open it up for comments. The second amendment is the inclusion of children and pregnant postpartum women in the dental services demonstration. This is a result of Appropriation Senate Bill 2, Item 138, titled Shift Medicaid Dental to All to University of Utah, which was also run in the 2025 general session. With this amendment, the state seeks authority to transition the dental benefit delivery system for children under age 21 and pregnant and postpartum women from managed care to the University of Utah School of Dentistry and their associated provider network. As far as the eligibility, individuals eligible under this demonstration must be pregnant women, including postpartum women, or children enrolled in Medicaid. There will be no changes to the dental benefits provided to eligible individuals under this amendment. Individuals will continue to receive the state plan and dental benefits, and cost-sharing requirements will align with those provided under the state plan. We intend to implement this proposed benefit as soon as possible after approval, but no sooner than July of 2026. And the projected enrollment for this shift for these individuals to be covered under UUSOD is approximately 200,000. So that is the summary of the two amendments, and we'll now open it up for any comments or questions.
Can you just say one more time when the other public hearing is?
Sure, it's this coming Monday, the 21st, from 4 to 5 p.m.
Okay, thank you.
Yes, Jennifer?
I did wonder a couple of things. With moving the Medicaid dental to the U of U School of Medicine, School of Dentistry, I mean, what is that statewide? So people that are very rural, very far away, they have to get all their dental care there? Do they have outside, like satellite clinics? I wasn't sure about that when I heard about this initially. My first question. And the second question is, there's no ACO component to this, right? There's no reason that, I know we work with disabled kids. We want to make sure that there's not any incentive to not allow those disabled children to have sedated procedures when they need them for cleaning and other cares. It sounds like it's not an ACO model right now. It's a regular funding model. I just want to make sure that, there's access statewide, if that's the case, and then just clarifying the funding model. Thanks.
I can take that. I'll take
Yes, thank you.
Yeah, thank you.
Thanks, Jen.
So Dr. Britton, this is an expansion of our existing relationship with the services that we have established in a fee-for-service model in partnership with the University of Utah School of Dentistry. And what the university, so it is fee-for-service in the sense that the claims are billed to fee-for-service, the prior authorizations and the policy is established by fee-for-service, but the provider network is administered through the University of Utah. School of Dentistry. It is a statewide model. And they have developed what's called an associated provider network. And Brian's including the list there in the chat that actually lays out all the relationships that exist today with dental providers across our whole state. So this group does do a Utah tour and does sort of education across the state, educating dentists about the Medicaid program and the scope of services and the reimbursements, and takes questions and all of that, and describes how the model works. And that's been ongoing now for a number of years since we've begun partnering with them on adult dental services. And then as you see, there are these sort of requirements around even still fulfilling access to care standards that you can see with regard to the geographic breakdown of that list, I believe. I don't have it open, but I believe it does have a kind of a geographic breakdown so you can see where providers exist. And so the University of Utah School of Dentistry will continue working in partnership with the Utah Dental Association and other dentists to build up this group of specialists perhaps that specialize in pediatric dental care, and those general dentists who are already providing services to Medicaid members to affiliate with the School of Dentistry. And so they are not actually becoming University of Utah employees, but more of an affiliation with them, if that makes sense.
Thanks so much for the clarification. Appreciate that. Appreciate your work on this too. Thanks, team.
Any other comments from anyone on any of these waivers? If not, I think we can move on to next. As a reminder, there's another chance to comment through the second public hearing outside of the MAC, and then also through public comment as well. So if you don't want to speak your comments, you can always write them as well, and you can submit that at your leisure before the due date. And what is the due date for public comments? I guess that's my last question, like written.
Oh, sure. Sorry, I forgot to mention that. Apologies. The public comment period began April 8th and will run through May 8th.
Gotcha. So you can submit written public comments through May 8th. Sometimes I think that those are easier, in my own opinion. So if there are no other comments, I think we can move on to federal reform updates from Director Strohecker.
Okay, thank you. I appreciate the opportunity to just share with you for a few minutes a bit of what is happening on the federal side. And note, it could have changed 5 minutes ago. So it is certainly actively moving. There's some slides I'd like to share with you on this. And I know I have 40 minutes set aside to go through this. I don't think it's probably going to take 40 minutes because since we met last month and we had the opportunity to just go through sort of that detailed breakdown of all the different proposals that do exist, there has been some movement, but not significantly enough that I have like big updates to share with you with regard to what's happening on the federal side. So let me just walk you through. I'm sharing with you some resources that were put together by our National Association of Medicaid Directors, and we're happy to distribute these resources to you for your review afterwards. But just wanted to at least orient you to where we are in the budget reconciliation process. I think this is really helpful as it kind of gets confusing as the media may come out and put a headline that the House did this or the Senate did this or Congress marked this milestone. And what does that actually mean? And it certainly is something that I've had to learn a lot more about as this is a very complex process. And where are we in that process, right? And what does that mean? So I think I'll just start first and foremost. I know I have this screen up, but I want to just back up a second and say that we are still very much working towards this. I shouldn't say we, the feds and Congress are are still working towards a budget reconciliation package with a significant reduction of still the target of $880 billion. And as the groups work through this process, I just wanted to reorient us to this very significant figure that has been put forth and has actually moved forward from phase 1 to phase 2 of the process where we are today, that we are still looking very much at this $880 billion cut. And when you look at this, as of course we've discussed previously, is that this amount of money is very difficult to achieve this type of federal reduction without really looking at significant changes to the Medicaid program itself. Some of the narrative that we've been hearing more recently as they've been kind of maturing this conversation is that rather than moving from Medicaid cuts, they're really trying to position some of these proposals towards reducing the growth of Medicaid expenditures. And so I think maybe with that frame of mind, you can perhaps, I'll give you a glance at what we were given yesterday with regard to what's on the list. And I'll give you a glance at that to see sort of what's highest priority. But I think as they're looking at a very narrow margin in order to get something passed and trying to understand what is needed to really achieve this type of savings in a very tight in a political environment, I think they're looking and actively negotiating. So like I said, what's happening right now could have been different than it was an hour ago. So first of all, I really feel this is a really nice breakdown of sort of the expectations and the different steps that we can kind of keep track of as this conversation moves forward. At step 6, I think one of the timelines that's really important to note is not just where we are in the process, but what kind of timeline are we working up against? And I'd say the real true timeline that Congress is working towards is a date of September 30th as the very last date that they have to really make their final decisions on this, which is the end of the fiscal year. However, with that in mind, we've been shared from NAMD that, certainly these recess times, and there is right now, we know there's a Memorial Day recess, and then there is an August recess. Those are common times when we may see some final work done. And so knowing that Memorial Day is now just, a little over a month away, certainly there is a lot of interest on what could happen even in the next few weeks. And so we'll certainly keep you apprised of everything we know when we know it. So looking at this, right now we have certainly passed out of step 1 and we are currently in step 2, which is it's moved out of sort of these separate areas of the House and the Senate, and they're kind of moving forward with an agreed upon resolution. And that resolution that was agreed upon certainly does include the $880 billion cut that was proposed by the House. Where are they at now? As step 2 notes, the different working groups and the committees are working to write the different reconciliation bills in accordance with the budget reconciliation instructions. And so right now there's a lot of talk and I think negotiation, but also consideration of how they're actually going to, in these working committees, actually craft these types of proposals that will actually achieve this type of savings. What we know is that by step 3, this has to begin by the end of this month. And so we believe that things will move out of committee and perhaps into step 3 within the next few weeks. And of course, as you see this and anticipate that, as I said, there is this Memorial Day recess at the end of May, that there could be a lot of activity happening by the end of May before the Memorial Day recess. Of course, it may take longer than that as well, and we may see a longer window of time where there's work, but there certainly are these sort of dates that I think the folks that we work with and are kind of the insiders are sharing with us the steps and sort of where they are in the process and the conversations that they're a part of as this work advances. Now, what's on the docket right now? And I think that's something we certainly have really thought long and hard about is what is on the proposal list right now. Last month when we met, I went through a pretty long list of things that had been put up as potential options around changes to the Medicaid programs themselves and Medicaid financing that would help achieve those goals. And I think now, according to the information and I could say the reconnaissance that's been done on behalf of NAMD and others, NAMD has recently put forth this document to share what policies are likely to end up in the reconciliation package. So again, this is just kind of using the information that they have from some of their inside resources. As I said, this can certainly change and it may look very different than this, but we are feeling more certain as we think about not necessarily cutting the program, but kind of controlling the growth of the program, that these are some places that have certainly gained a lot more attention and are certainly more focused with regard to opportunities they have to hit that 880 mark. So I'll walk through them very quickly and walk through sort of this very likely list and what's on it. And I think I won't spend too much time in these. Of course, myself and members of my team can answer any questions that you may have to these specific proposals, but you see these four items that are on the very likely budget reconciliation list to make it all the way through. And so one of the things that we certainly see are a rescission of some of the Biden administration rules that were put forth. A year ago, we, in a very quick succession, received about 5 different rules from the Biden administration looking at different changes to the program. 2 rules specifically that are up for rescission are the eligibility final rule and the nursing home staffing rule as well. So looking at this, certainly there are numerous components to the eligibility rule, some of which we've already put in place at this time, and then others that we have planned out for future releases in our DWS's EREP system or as part of our program design and policy work. But certainly that is one proposal that is up, and believe that there could be significant in the ballpark of about $200 billion of savings with the rescission of these 2 rules. The nursing facility staffing rule came out of our access rule, and it looked at nursing facility nursing ratios, and it came up with a minimum threshold of patients per nurses for that. And I think part of that was looking at, if you were to pull back on both of those, what are the opportunities for savings? Another item that's been certainly part of the conversation all along has been mandated work requirements. This, I will just say for now, is that when you look at mandated work requirements, I don't have a lot of detail on exactly what that means. If those would be federally mandated, that would go into the state plan as a state plan requirement. Would it be for expansion or able-bodied adults broadly across the Medicaid population? What is the flavor of the work requirements? We're looking at previously released legislation or guidance documents or newly released proposals that have been put forth. We certainly know that as part of the work requirements discussion today, 2 states have been really central to this conversation. That would be Georgia and Arkansas, and they have had a lot of input on the federal side with regard to just engaging in these discussions as they occur on the federal side. And we're certainly getting feedback from them in our larger Medicaid director work groups and even in the smaller groups that I participate in. Certainly work requirements and mandated work requirements is on the table. As I had mentioned last time, provider taxes. Right now, there is a maximum of 6% provider tax. that is established across different provider types. For Utah, we have 4 different provider types that are taxed today. And that would be our hospitals, as well as our nursing homes and our intermediate care facilities, as well as our ambulances. And the proposal here is that you would take the 6% provider tax, and it would have a lower percentage. And numbers have been reported like 5% or a variable approach by provider type, for example, so that, you know, perhaps it could be reduced to 5% for one provider and a different percent for a different provider. But that is definitely on the table for discussion as well. And then something that is not specific to Utah, because it's certainly called out as the District of Columbia, but there is on our federal match, as you know, Utah's FMAP or federal match, which is really, as we look at it, for every dollar spent on the Medicaid program for our traditional program and services, there is a calculation looking at our income that would calculate out to what the federal allocation is and what the state allocation is as well. And there is a floor today on a lower, an established floor that says a state will never pay more than 50% of their traditional costs. And what this proposal is that the District of Columbia, who might be at that 50% floor, by the way, Utah is at about 62% in our FMAP today, so we are not anywhere near the 50%. It has been trending down, but it would be to lower the District of Columbia's FMAP rate, and with that, they could gather others additional savings. So those are the very likely column that we've been focusing on. And go ahead, I can pause right here. I think we'll just say somewhat likely and less likely. And this is, of course, based on information that's been gathered through our federal partners and from conversation that's been having with insiders. Go ahead, Stephanie. We're happy to take questions.
Thanks, Jen. I appreciate it. I had a couple questions. So my first question is of whether it's these very likely or whether it's like, yeah, maybe of like the very likely and maybe in the somewhat likely columns, like which policies are you most concerned will impact the justice waiver and like the work being done around, like I saw a rule rescission about HRS and like the non-medical social needs stuff that I didn't have time to really dig into, but like I was just curious about like whether or not that's going to impact any of the justice waiver. Anyways, I have 3 questions, so that's my first question.
No, that's great. I think that's a really great question, Stephanie. So first of all, what your question is, the 1115 justice waiver, what do we think of any of these that are here laid out today would have the most direct impact? And I would say in my time, in my perspective, the reduced FMAP for expansion could have the greatest impact on our reentry work that is laid out in our 1115 waiver. The reason for this, as those in the call well know, is that if you reduce the FMAP for expansion, it would enact our trigger law. And while certainly we could call a special session and work through what that could be, the reality is if the trigger law would enact, it would dramatically reduce the number, the population that would even be eligible for our reentry waiver. And I think, you know, looking at like, do we keep the waiver? Do we not keep the waiver? I think it would affect the waiver. Does it mean we wouldn't keep it for other populations and serve them through it? I think certainly we would absolutely consider that. But I do think as you consider the percent of expansion adults that we expect to be served through the 1115 waiver, it's by and far about 70% of the population is our estimates. Would likely be on the justice waiver, and maybe about 10% of TAM, a remaining 10% would be TAM, right? So an FMAP would enact the trigger law on expansion, but it would also impact the FMAP on TAM, which may also warrant another conversation about that as well, as you know, right?
Okay,
So TAM is not subject to the trigger law. but be with any change in FMAP, right? So I think
Yeah.
those are the two groups that would be potentially impacted by any change in FMAP.
That's helpful. Thanks. And then my second question is,
Could I add one other thing real
of
quick?
course.
One other thing that I think is on my mind, and something we've talked about when we've modeled out the per capita caps. And this scenario it is difficult, first of all, to model, because as we built our modeling tools, the inputs of that model may be subject to change, right? So we're using the best information we have to develop a per capita cap model. But one of the pieces that we would have, for example, if we were to use a historic year on per capita caps, it would establish sort of this base federal funding at a historic year. We have not gone live with reentry yet. And so when you consider the impact of future expenditures and the federal drawdown on a per capita cap model, it would have a significant impact on our entire program, okay? It specifically would affect adult expansion services being at that 90-10 match rate, and any new services that we have targeted for that, including housing, including our reentry work, and any other growth, provider rate increases that were approved this last session, for example. We've modeled some of those. So I think that also is something that is very present in my mind when we think about some of these other things that like crop up. Per capita cap sort of crops up, and states talk a lot about it. And as we look at this, I think it's really important we're cognizant of what that means to any new legislation or changes to our program. So anyway, I'm sorry to get in front of you there, Stephanie, but I didn't want to not mention that because it's been on my mind with regard to how that would affect our future work that we have not yet implemented.
No, thanks, Jen. I really appreciate that. And I agree. So I guess one of my questions, so whether we look at the provider tax one or some of the other, I know that it's being pitched as savings. I don't name any policy. I mean, some of them it's unclear whether it's savings or just a cost shift, because ultimately, right, when we think about the justice waiver, that's going to be hugely beneficial to the county sheriffs, to jails, to local governments, to the criminal justice system. And I think that if it was to just be removed, then it becomes I think there's sometimes a shift in cost, and it's about who's going to pay. So maybe they'll say it's a savings and the reconciliation, but ultimately a lot of these needs don't go away. And if they do, it's probably because there's been closures, which is going to trigger a recession, or there's been deaths, which is just tragic. So I think it's just an interesting thing to consider. And is that some of this stuff is not the actual waste that someone
I think you're right. And I think the one way that I think is helpful to think about this is one perspective is shifting the cost from the federal side to the state. And so, I mean, some of these proposals don't mean we're not going to bear the cost. It's just the feds are not going to bear the cost in the same way. It doesn't mean the state will not bear the cost in some capacity, right? And certainly, that's a little bit why I presented, these are the types of services that our adult expansion and TAM members utilize today. And, who's going to bear the cost if those services, if it's not run through the Medicaid program. And so if it's, the emergency rooms in the hospitals or the county, health, behavioral health providers and others, it doesn't mean the costs go away. They're shifting some of those costs from the Fed side down to the state.
Yeah, exactly. And I guess so with the provider taxes, for example, I mean, would this repeal the assessment that the hospitals pushed through a couple of years ago? So I understand that, because really that was something that went straight to the federal deficit. But if there's other ones included, but even that one, is the repeal of that, is changing that provider tax then assuming that the state will then, so there's some policies, my understanding is that there's some policies where the assessment or the tax is for an essential need, and then there's some where it's an additional kind of revenue stream almost for like some provider group, like they put up the cost, they get the federal match, right? So for the ones where it's like an essential need, like the provider assessments in some states pay for Medicaid expansion, or, and I know here it contributes a little bit, but in those situations, like, are they assuming that by taking away that tool, they are then shifting the state, like shifting the cost onto the state without assistance from the provider assessments, and then just like expecting that the state legislatures are then going to just like pull back on Medicaid itself? And that's how the federal, like, how do they find the money? How are they understanding this to be a way that they're going to generate, you know, alleged cost savings?
Yeah, and I don't know if someone else on this call wants to help me with this, Brian, or I don't know if Michael Keith is on this or others, but I'll say, first of all, states do an array of provider taxes, and they use them in different ways, like you're saying, right? And I can say for our state, and I want to speak specific to the hospital tax, is that as we, and I don't think I have my one pager up. Let me pull my one pager up here quickly. When we look at where our facilities who are being taxed today, where they're at, the hospitals are, based on FY25, I believe they are at let me pull my one pager up here, 4.4% or so, I think, is what it was at. They're not near even the 6% threshold. And so I think if you're still below that, you just continue with where you're at, right? Let me see if I can find this here and share with you what I'm seeing. Okay, so let me share another document here with you. And I don't know if maybe Nate's on the call as well, but I could, because I feel like Nate just hopped in the document. Nate, if you're on the call, and you can explain this a little bit differently, but I want to make sure I'm actually answering your question properly, Stephanie. But one thing I can say here in Utah is when we look at this particular, are you able to see my screen right now?
Yes.
Like it's black.
Yes.
Oh, there we go. Okay. So let me make this just a little bit bigger, but we've done a series of a few one pagers. You can see we just have a few here that kind of lay out where we are today. And so if you look today at where we're at with our hospitals, they are based off of today's figures and what's moving through that tax today. They're at 4.42%. Our nursing facilities are a little closer to that 6% limit, and then ambulances are at 4.2%. Okay, so your first question was, would that get rid of the average commercial rate? And I would say that that does not mean it would get rid of the average commercial rate. We're still below. If there's a 5% threshold, we would still be at the 5% threshold. Does that make sense? Within that 5, based off of these numbers. And I think they were distributed last month, but we'd be happy to share them again as we went through them last month. But anyway, did that answer your question, Stephanie? So I think it keeps sort of the approved amount. I mean, regardless, one of the areas where I know that CMS is giving more scrutiny is actually through our directed payment preprints. So even when we calculate out like what these taxes are and how we make these arrangements, they need to be put through a process where CMS is actually seeing, well, how are you calculating this number? And specific to the hospitals, we submit a preprint based off of a base year of data that estimates what that amount will be. And we have to really demonstrate, like, this is how the average commercial rate was calculated. And based on this is the amount of money we would anticipate would move through that provider tax. And different taxes function just a little bit differently, but they are done in conjunction with CMS review and approval in order to actually operationalize these, because you're pulling down so many federal dollars as well, as you know. So I think, you know, I don't see these processes working independent of a CMS thing. If there's a different relationship, I might not be aware of it. And like I said, maybe, I don't know if Nate's on this call or somebody else who could maybe help me out, or Brian, if you feel like you could answer the question. But
I think agreeing with everything you said. I think the other piece, Stephanie, I think you hit on was that, some provider taxes are just to fund programs and some support rates. For example, in Utah, a hospital tax was instrumental for expansion. And wasn't directly tied towards rates. And the federal proposals that I've seen have been very limited in detail, and I don't think that they make that nuance about what type of tax would be allowable for a state, what type would not be allowable. I think the only proposals we've seen at this stage is just a reduction in that 6% figure. They don't get to the level of detail that you're asking about.
Okay. Thank you. I guess it's just, I think I was just trying to understand, like, are they just assuming that without using the provider assessments, that like the states will forego certain either rate increases or program additions, which then is going to trim the federal budget too? It was just very unclear to me how this is actually going to, like, how they were going to find a bunch of federal money, because I was just thinking they're just assuming the states aren't going to make up the difference.
Yeah, I don't know that we can answer that question. We can certainly take it back for more research and see if we can get into some greater detail about how they came up with these estimated savings and how they're projecting these. But I apologize. I don't know, Brian, I don't think that's something we can answer right now without taking the question back and maybe providing a response to you.
Agreed. Yeah, I mean, a lot will just come back to the Congressional Budget Office and how they score it. And I don't consider myself an expert in what goes into those scorings, but yeah, we can try to share what has been published on CBO scoring. Yeah, I think you're right that they are making certain assumptions about what matching does and does not replace those assessments.
Okay, thank you. I appreciate all of that. And I think that is, yeah, I think it would be, I would be curious about like how you all are looking at back to the likely, the tiers of likeliness gen list, and like which ones, under which scenarios, whether it's like a recession or whether it's like a fertility rate increase or a new health disease like a public health emergency, or just like new program additions like the justice waiver, like how different policies may be impacted like in those scenarios, because I do feel like that's something where it's like that kind of long-term planning that I feel like maybe some elected officials could really benefit from, because I don't think that's something that they understand how kind of intertwined like Medicaid is with so many other things, like whether it's like helping a state bounce back from like an economic recession, or, helping if like there's a bunch of new babies born, or just things like that. And just wanted to just see if that's something that you guys have also done like projections with. I know you mentioned you guys have done a lot of like modeling, and I'm just curious if that's something you've also modeled.
Yeah, I do think it's something we've done the beginning steps to, and we need to probably continue to refine our model to be able to do this. But part of even modeling, even for example, one of the exercises we've been trying to work through is just looking at this past legislative session and some of the items that were funded and put through. As we have to model, we have to, again, it's what base year are we working from, right? Because that really sets your spending amount that you would get. And looking at those base year data, recognizing that kind of establishes your federal amount that you'll receive. But we've run a few items through that and anticipate, this is again, in kind of the earlier phases of evaluation and testing, and I want to get more feedback from some others to really mature this evaluation. But I think it's important for us as we even present this to others to look at. So based off of this data and the inputs, we've designed our per capita cap modeling with if we were to run this, and I'm going to choose something randomly, like this nursing home increase, for example, through what would it do to the per capita cap model, right? And it's almost like it would require, in some ways, it would require during legislative session in this type of model that you almost have to think about that in mind, right? And then it gets really complicated for us looking at, general fund and expansion fund and things like that. But even if you look at just the federal allocation alone and think about this is how much you have on a per capita cap model, and then you're introducing changes to that model, it can bear a little bit of change. It can bear a little bit of inflationary growth or changes up or down, and then as well as some enrollment changes up or down, but it doesn't, it's not sensitive enough to adjust in times of like huge change, I think is what we recognize and appreciate. And so I think that's where some of the challenges with the per capita caps and the block grant come into, is that it does really limit and restrict the program's growth.
Thanks, Jen. I appreciate all of that additional information. Thank you.
Yeah, you're welcome. Go ahead, Andrew.
Jen, following up on Steph's questions, she brought up and reminded me the health-related services and supports that and I think to a degree the answer is probably going to be similar to the justice waiver, but I was just curious how you guys are thinking about that work going forward, given the uncertainty that we're seeing and hearing about now.
Thank you, Andrew, for the question. And I did want to touch on health-related social needs and also just share with this group our intent to continue moving forward until there is a different reality that we are dealing with. We are actively working with Salt Lake County Jail. We're actively engaging with Weber County Jail as well, and working with the prison, and still, implementing system programming changes to support the justice work. So with regard to our engagement in reentry and our engagement in health-related social needs work, nothing is changing at this point in time. With that being said, there's a couple things I'd like to comment on. First of all, we do have some upcoming things even with HRSN within the next few weeks. I would say even maybe within the next 2 weeks, we will be releasing an RFP for medical respite services. So again, this is a new program for adult expansion or TAM members that would provide up to 60 days of medical respite services within a setting of care. There's going to be 2 settings that will receive this RFP, and it will provide up to 60 days within a calendar year. Brian, just nod to make sure I'm getting the specifics correct. Thank you. And then, and this would go towards some of their overall housing cost time frame too, if they were to also qualify for the 6 months. But that RFP is going to be released. So we are moving forward with that. And then additionally, we're expanding HRSS services this summer sometime to really bring in adult expansion, and then at a future state support our reentry work through any justice involved individual within 12 months of justice work. So it's not stopping our work. And there's a reason it's not stopping our work, because we don't necessarily believe like some of these things could change. If we lose expansion, if the trigger law enacts and we lose expansion and that affects the expansion fund, it would dramatically affect our reality around adult dental and other services, right? But at this point, we continue to move forward. The second piece I wanted to note with regard to HRSN is that there was a federal action around, CMS action, I should say, around states that did have pending HRSN waivers, where they had stopped the review of those waivers and were not moving forward on them. And I'd say that for us, there is no indication that there will be a change on our existing waiver. I think they've paused the work on current applications. And I think that may have been a news feed that was released but they are not doing, and in fact, we had a little bit of time with the our new head of CMCS, Drew Snyder, and he did say that there is not a change to HRSN, and it's not on the table at this time. But I know they paused new states applications. Does that answer your question, Andrew?
It does. Thanks, Jen.
You're welcome.
Jen, do you mind pulling that slide back up?
Not at all.
Thank you for taking all the derailments of the
Sure. Let me pull
conversation.
it up. I think I actually closed it accidentally. So let me actually restore the entire thing here, because I think I don't have it downloaded. Hold on. Oh, Brian, do you have it handy? I know you are.
Oh, yes.
Do you mind displaying it real quick? Just the third one. I'm so sorry. I closed that screen and.
No, you're okay. I got it.
I was curious about, like, in that somewhat likely, the FMAP penalty for undocumented coverage. And I was just curious about whether you all are worried about state CHIP.
I think this is an area of focus for this administration, so we're monitoring. But I think certainly, at this point, I wouldn't call it worried. We're monitoring the discussion in this area. But as you recently and may have just noticed prior to this, we had our CHIP Act meeting and announced that we do have an open enrollment period. And so, again, we're moving forward with that and continuing to serve members that qualify for it. So I think at this point, we continue to move forward and just monitor what's being discussed on with regard to that specific bullet.
Great. Thank you, Jen.
You're welcome.
I'm glad to hear that there's open enrollment for those kids. Thanks for continuing to do the program.
Any other questions we can answer regarding this?
I feel bad for dominating so much of the conversation, but I do have another one if nobody else is going to jump in. I just been watching, like, the way that, like, the conversation's been going with different politicians, and when you mention Arkansas and Georgia as states that they're watching, I find Utah has an incredible Medicaid program. Like, they should be modeling programs after ours. I'm from Arkansas, but, like, I mean, we should not be modeling programs after states with high maternal morbidity rates. But I was curious about whether or not you're picking up on, like, the fraud, waste, and abuse, and if they're going to, like, start doing eligibility things that I'm going to hate with all of my heart. I know that some of the organizations that work with Arkansas and Georgia on their work requirements are also, those organizations have been pushing some, they want double verification of household size. Like, they want incredibly scrutinized eligibility requirements that would just create such an administrative burden that you would see drop off because people could not prove things about their lives that are true. But, like, it's very hard to prove some of the things that they want to prove, turn from self-attestation to, like, verification, right? And I'm just curious, are you picking up on that? Are you guys hearing anything about that? Or is it just like we all might hear the same thing, but we don't actually know what it might look like?
Yeah, I'll say the one specifically around eligibility, the one area that has just caught our attention isn't the place where you're talking about right now, but certainly there is more interest in sort of out-of-state beneficiaries. And, there was a Wall Street Journal article that looked at, during the pandemic, of course, folks who were enrolled in two state programs. And sometimes that did happen because we know we didn't necessarily have all the information to know some of those things. But I think they're looking at out-of-state beneficiaries a little bit more closely. But other areas around eligibility, I'd say, honestly, not a lot right now. If anything, it's more frequent eligibility reviews. And also, even to the comment, believe it or not, when we had an audience with Drew Snyder, it was, a commitment to continue to simplify the enrollment process as part of just the waste piece, right? That the enrollment process alone is very arduous and sometimes can be wasteful. And that was one area they called out as an area they wanted to continue to focus on and improve. But other than that, I don't know if others from the team here or even from DWS would like to call that out if they've heard anything or experienced anything. But for us, from my perspective, Stephanie, and what maybe I think like we've heard more of from the federal side, at least through the Medicaid directors, it's been more about more frequent eligibility checks and maybe the out-of-state factor for folks.
Yeah, I think I would agree, and just some of those more frequent eligibility checks may require congressional action. I mean, you see it in that middle section, so Congress is considering it, but a lot of that would require federal law change in order to enact.
Cool, thank you.
Anything else we can answer for you? Okay, well, we have the rest of the meeting. So certainly if something else comes up, you can ask us at that time. We're happy to take your question at any time. So thank you, Rachel, for the opportunity to give some updates here.
Yes, thank you for the continued updates. I'm sure there'll be more to discuss next time too. I think next, the agenda's up on here. Thank you. Next, we'll go to an eligibility and enrollment update from Michelle.
Yeah, hi, Rachel. Hi, everybody. I'm going to go ahead and display my screen here. In a second. Okay, hopefully you all can see that. I'm going to go ahead and drop this like I always do into the chat here. This is available on our website for those of you who are not aware. So anyone can access the enrollment report each month. I am on the Persons tab in this first tab here on the interactive graph. As of the month of March, our total enrollment is 352,950 individuals. If you move over to the data table, there really, as I was looking through this, I really didn't see any significant changes in any of the Medicaid coverage groups. Again, I know I've mentioned this, I think the past couple of times, but we do still see a steady increase in pregnant woman Medicaid. I do believe that could be attributed to the 12-month extended postpartum coverage. But currently we're at roughly 13,903 individuals on that. But really on all of the other groups, I don't really have anything significant that I would point out here. But again, you guys are all welcome to go into this and check it out for yourselves. You can play around and look at these different tabs with the different groups. I did want to show, as I always do, the eligibility data dashboard that's also on our website that gets updated every single month with outcomes that we still report over to CMS. We are still doing very well with our ex parte renewals. We're at roughly around 37%. The number I want to point out, I think I pointed this out last time, is the percent of members who have a review still pending. That has gone up since January. It's at 14.5%. We are attributing that to the implementation of the eligibility final rule provision that was effective in January, and ensuring that the coverage and transitioning between programs and people were not losing coverage until a full determination is made. So we believe that the implementation of that has helped with that number. So something there I wanted to point out. There are other tabs up here as well. I'll drop this in the chat for you guys, for those of you who may not be familiar how to find this either. So you can go onto that and look around for yourself. But I do want to point this out, and I know I have Melissa Presley with Department of Workforce Services on the call as well, and she can chime in and add anything. But I did want to point out the call wait times have gone down significantly the past couple of months. They're down to 13 minutes. So if you see clear back here in June of last year, they were at 40, and DWS has them down now to 13. So just kind of wanted to point that out. I think that was something good to show. And Melissa, feel free to chime in and add anything you want there. But I did also just want to share, not necessarily go through it, but Rachel, I believe you had requested this a while back, but just a dashboard for the LEM 15 waiver items. So I'll drop that in the chat too. That gets updated every single month. So if you are interested in looking at those programs that are attached to the LEM 15 waiver, we have that dashboard online as well. So I'll stop there and just ask if anyone has any questions for me.
I do. And thank you for that, and thank you for the creation of that last dashboard. I know I did specifically request that, so thank you. One question I have, and this is under the eligibility data dashboard, and it's kind of about a definition, like how something's defined. So when I'm looking at under the other DWS eligibility activity tab, I'm looking at applications average days to decision. And my question is if a case is procedurally closed, like to use unwinding like terms, does that count as a decision? And are those counted in days to decision? You might not know this right away too. So
yeah, no, I think very great question. I'm going to do my best to try to answer from what I think I understood you asking. So on this chart right here on the application average days to decision, did the procedural closures from unwinding, is that reflected here? Is that what you were asking? Sorry.
Well, I'm more like, so sometimes a case can close on Medicaid, say if the person stops responding or they don't provide the right type of information. Is that ever, like, is that considered a denial under this, or is that something different that, and that data doesn't really go into average days to decision? Like, is that encompassed under denial or?
Yeah, no, great questions, Rachel. And there is a difference between a denial and a closure. So when we talk about denials here, we are specifically talking about applications, not someone who is currently receiving benefits and is closed for that procedural reason that you just defined. Those procedural closures show here in the very first tab on the review outcomes, when someone is closing at review for failure to provide information, like that will show here in the procedural, the last month in March that we reported for this, we are roughly at 25% of procedural terminations or closures, if you will, right? The piece of data that is not captured here that I think you might be trying to get at is in between a review period, right, on a change report. And if someone closes because, let's say, they got a job and I sent a form for them to provide and they failed to provide that form and they close, right? That's considered a procedural closure in between their renewal period. We don't capture the data on here. So that's not currently captured on this dashboard. And hopefully that's what you were asking.
Yeah. So that is what I'm asking, like whether it's a new case or a renewal or something like that. It's something that I'm interested in because I am working with someone who and I haven't gotten involved in it because they've asked me not to, and that's fine. But there's a situation where someone's been applying and trying to get on Medicaid for some retroactive coverage, and it'd be a very small period because they're only unemployed for a very small period for basically months now. And it's not the first time I've heard stuff like this. So when I see days to decision, like a denial being 18 days, that seems quite short to me. So I think that there's maybe some data that we're not capturing is like that really long experience of applying for Medicaid that's been over, quite frankly, months. So that's why I ask, and I wonder if there's a way to capture that data, because I think that that's something that might be falling through the cracks in terms of people, just a really, really long process to get on the program while they're receiving bills. And
Yeah.
so that's, and we're not going to probably brainstorm something right now, but it's a piece of data I'm interested in, I guess.
No, and I think it's a really excellent question, and you're making a good point. And I would love, possibly with Brian, myself, and even Melissa Presley, maybe offline, work with you, Rachel, and trying to identify exactly what you're talking about there.
Cool.
Okay.
Does anyone else have any questions for Michelle? I didn't want to monopolize her time.
Okay. Thanks, Rachel.
Thank you. And then we'll go back to Jen for the director's report with upcoming policy changes.
Yep. Thank you, Rachel. Okay. Have a few things we'd like to share today. First and foremost, want to just announce that since our last meeting, we have officially gone live with our adult dental benefit for our adult expansion population, and wanted to just share some like really early data that we've had on utilization. And I thought it was just a very positive thing to share, recognizing that Medicaid providers do have 12 months to bill. We've been able to get a little finger on the pulse of what's happening and how members are utilizing this service. And to date, what we have since it started on April 1st is that we have a record of 248 new dental visits. So what that means is 248 new individuals who didn't previously have full dental coverage like they do now, now have access services. And this is just for what's been billed. And so I think that was something that our team was very encouraged about. Additionally, when you look at utilization of some services are under a prior authorization, which is within our Medicaid team here. And so we're able to get a sense of sort of the prior auths that are coming through and what those services are. And I'd say that it's been reported to us that the prior authorizations have increased by about 60 a day since adult dental went live. And of this, a large percentage, and we're saying more than 50%, are related to dentures. And so not every dental service, of course, is on a prior authorization. Dentures are, but when you look at some of those some of those requests, I'd say actually it was closer to 75% of those requests received so far have been for the coverage of dentures. And so we wanted to share this information with you. We recognize before this program went live, many of you on this call have asked about this and have stated that's a question we get often, like, when will we have dental coverage? And I thought this was a very positive message to share. And our team is certainly encouraged by what they're seeing, and adult members are certainly able to utilize these services now. So that was one update. The next update I wanted to share was an important milestone for us, and it did serve as a press release that was put out on Tuesday of this week by the department. But I wanted to announce that we have received certification from CMS, our federal partners, on our PRISM system. This is an important milestone for the team to receive, and I'll just call out a couple bullets with regard to this press release that was put out. So first of all, what does it mean to get CMS certification? So CMS certainly evaluates our PRISM system, which is very large and complex. It handles all of our Medicaid, the majority of our Medicaid business, our claims, our eligibility flows through here, our prior authorizations, provider enrollments, and so many other things. And when you look at how that system in totality is functioning, we had 8 new modules that went live 2 years ago when we launched this program. And with it, we've kind of been going through this exercise of auditing the program all along. So certification has been kind of happening through the process to make sure we actually could go live, for example. And then after we went live, CMS was still evaluating our reports and the different things that were being produced out of the system to really validate the work of the system and to ensure it met their standards. Some changes that have occurred with our federal partners over the years and more recently is that they require outcomes-based review now, whereas in the past, they would certainly look at the system and evaluate it a little bit differently than now. It has to achieve certain outcomes, and our PRISM system met all of those outcomes. And so with that, of course, there was an official press release we could share with you. Perhaps it's maybe Colby's on the call out here and can have the link. But I wanted to share this was a really important milestone for the system. When I think about what does it mean to be certified, it is an enormous audit of the system to ensure it's handling the work of the Medicaid agency within the thresholds of performance that CMS requires. And it has met all of those and passed it. And I just wanted to share this good news. That does not mean, by the way, that we do not recognize that there will always be continued work in our program. We recognize there are still some things we are working to post-implementation to continue to work towards an improved state on and clean up some outstanding work. But going forward, we're really thrilled that CMS has signed off on this. So thanks for anyway, I just want to congratulations to the team, but also thanks for all of you who've been part of this process in one way or another as being a Medicaid provider, an enrollee, or others. And we appreciate being able to share this news. So the next item, oh, sorry about that, Colby. Okay, no link to the press release, but we could certainly send it with Sharon's materials and can make sure that Sharon can distribute that to the MAC committee members. Okay, last but not least, I have a fairly big announcement to make right now that I wanted to share with this committee with regard to a step that the Medicaid agency and the department is taking. We, as I kind of went through the federal updates and walked through where the feds are with regard to the environment of some of the proposals that are on the table with regard to the budget reconciliation items, certainly we're recognizing that there can be severe impacts to the Medicaid program through some of these changes. And certainly, as we look at one change in particular, work requirements, there's an update I want to share with you today around this. I'll preface this not to repeat what I've already shared, but to emphasize that its work requirements as they exist are on the short list of highly likely items to make it through the budget reconciliation process. And when I say work requirements, I already stated earlier that these are mandated and we don't know a lot of the details of what that could really look like. We've tried to keep our, very engaged in the conversation to understand what various elements of this may mean to our program. But as we have really been engaging in this work and thinking about how we'll navigate these changes, it has been a decision of the department to move forward with submitting an 1115 waiver for community engagement requirements for our adult expansion population. So I'm going to pause for just a moment and give you a little bit of background, if I could. The federal setting could be very different than what Utah has crafted. We recognize that some of what's been put forth federally is very different than what Utah has put forth. And when we look at even other states that are very engaged in this conversation today, and Stephanie already mentioned these states, Georgia and Arkansas. When we look at the impact to members, we recognize, as I try to really envision this in my mind, the impact to members, our intent is to put forth a proposal to CMS that really does consider the impact to members. And these times are uncertain, we know, but I think it's important for us to have a voice in the conversation. And we believe as a department that it was important to put forth Utah's version of work requirements into that conversation. And so And I know this is challenging. I know that there are folks on this call who may be on every side of this equation, okay? And so I appreciate that this is maybe challenging news to process for some, maybe just fine news for others, but I want to talk a little bit about where we're headed with this. So first of all, we do have a drafted amendment now. And this waiver is going to be announced in the Sunday bulletin, and it will be released for public comment on Monday. If you could, Thais, I'll get you in just a second. With this, it does submit our work requirement waiver and community engagement waiver into the public comment space. Let me talk about a few parameters, and then I can take questions before I go into greater detail. Oh, no problem, Thais. So what this will do, our specific proposal, and we will release much greater detail to you very shortly. In fact, we have a drafted handout we will share, and our waiver will be released shortly. But what I wanted to share with you today, first of all, is that this is a work requirements waiver specifically for our adult expansion population. So this excludes our TAM population and is very specific to our adult expansion members. With regard to that membership today, there are about 75,000 adult expansion enrollees. By looking at the combination of exemptions and different things that we've crafted within our proposal, we believe that about 7,900 of those 75,000 individuals would fall into those sort of work requirements eligibility category. This does not include those that have already fulfilled it because they also receive SNAP. So they may be participating in work requirements with SNAP. But of those 75,000, we believe about 10% of the adult expansion population would not meet an exemption. When you consider what this looks like, I'll just say we have a broad array of exemptions that align very closely with the SNAP work requirement exemptions. Specifically, some new things that have been layered in that were not present in our first waiver look at justice involved individuals, for example, because we didn't even have the program then, that if a person is involved in the reentry program, that they would not be subject to work requirements for 6 months. And then at that point, of course, could be evaluated for other exemptions. If a person is in an active substance use disorder program, if they are actively caring for an individual with a disability, if they're actively caring for a child under 6 years of age, homelessness as a category would exempt you. An exemption would last for 12 months. If the person qualified and met exemption criteria and or other good cause criteria, there are good cause exceptions as well, then that would exempt a person from work requirements for 12 months. Additionally, if a person was participating and actively doing this, but then could demonstrate an exemption, that would also qualify. And there's a lot more detail I could go into, but I'll hold for now. The other piece of our proposal also puts forth a suspension rather than a termination. So, for example, if an individual was maybe working towards but had not yet fulfilled the requirements that were outlined within the work requirements waiver, that they would be suspended rather than terminated for 3 months with the ability to then retroactively enroll if they were able to renew and refill. And some of these details we're going to have to work through a little bit with our federal partners, but that's the proposal. Additionally, there's a new piece where we are proposing to apply member supports, where we will proactively work with members and support them through this process. Again, details yet to be defined, but that is a new component of the waiver here. I think too, let me think here. I think I'll stop there and I can let me walk through one additional thing, and then Brian, I'll take your question. What does it mean to participate in a work requirement? What is required? And I would say we align with SNAP. Of course, I do want you to just, as you're hearing what I'm saying, and if you are or are not familiar with what's happening on the federal side or in other states, this is very different than some of what is presented by some other states. But what our participation requirements do involve are that a person creates a job seeker account with DWS. They complete the online evaluation. They complete the required online job training modules, and they apply for at least 48 jobs. So that is our requirement to participate and do this. Also, if someone is actively in school, doing community engagement, working, they can demonstrate those and get an exemption. So I wanted to just kind of walk through what does it take to participate in other states that have proposals out there. Those are different across states. And I wanted to make sure you had a little bit of early insight into what we are proposing. The complete, of course, package will be released on Monday. Go ahead, Brian.
Sorry. Yeah, thanks. I just I didn't hear a potential implementation date. What was the date?
I'll be honest, Brian, we don't have an implementation date.
Okay.
I think the uncertainty at the federal level and knowing what the feds will do, it's possible. Anything is on the table at this point. I think it's possible that mandated work requirements could require a state plan. Every state implements work requirements, and here's your state plan authority. They may allow an 1115 waiver with different flavors of work requirements as long as states are participating. They may, we don't know. What I do know is that our decision to take this step has been conscious of the federal conversations that are happening and our interest in introducing the model that Utah had CMS approval for in the past. Okay, we had CMS approval for work requirement, our community engagement waiver, and implemented it in January of 2020. So we are taking, by and large, it's very similar to that waiver from the past, and we want to introduce that into the conversation. With regard to the future, we have no idea if CMS will engage with us, will wait with Congress, will work quickly, or will take 2 years to look at the waiver. That's uncertain. I think our interest is being part of the conversation.
Okay. No, I actually appreciate the fact that we don't have a solid date yet, because that means maybe there's a chance it doesn't happen.
Brian, even if it were to be approved by CMS, it would still take at least 6 months to implement the programming and any of the changes that would be needed. So I think we recognize that even with CMS approval, if that would be forthcoming at some point, it would still take several months to implement.
Yeah, so at least 2026, I guess. That's okay. I appreciate it. Thanks.
You're welcome. Sheila?
Hi, Jen. Thanks for the information. I have a question. I'm wondering, is there a contingency plan or a plan in place, or maybe a plan could be thought of? The thing that jumps out at me on this is your chronic, years and years, substance use disorder, mental health issues, where they can go and they can work and they seem to be okay for a month or two, but then they're not okay. And is there a process or a thought around maybe fast tracking them back into Medicaid so that they can get back into treatment? I'm just wondering what if there's something kind of along that line.
Yeah, I think, Sheila, once you take a look at the exemptions that we've outlined, it does identify people with chronic conditions like serious mental illness, and people in substance use treatment programs, things like that. I think you could, it would be helpful to have your thoughts about that after you see the complete list. I think our list of exemptions, we may have, I don't know, more than 10 for sure, maybe 15 or more. So I'd like you to see those once they're released. And I'd be happy to take any questions specific to that at that time.
Okay, great. Thanks, Jen.
You're welcome. Go ahead, Stephanie.
Thanks, Jen. I mean, this is obviously disappointing. Sorry. We had this fight, before, so it's just disappointing because I know people who they don't have a diagnosis, Jen. Like, they don't know why they're sick. They don't know why they can't go back to work. Like, these are my neighbors. I'm so sorry. I know it sounds like it's not a big deal, but for them, just getting enrolled was like an answer to their prayers, Not everybody has like a diagnosis or like a definition of what's wrong with them. And I think it's like people live in communities where there's not 48 jobs and there's like potential recession coming. And if you're in rural Utah and there's like 5 businesses, like I think it's like really discriminatory against geographically. I think it's very discriminatory against people with like these unclear health conditions. And then just like for those of us that are kind of like the person that everybody asks for help, like, oh my gosh, have we not done enough? Like, it's exhausting to help over and over and over again and then backslide. And I understand strategically where you're coming from, but like, it's so frustrating because it's like backsliding and it's hard to watch it happen. And I know that it's like a hard situation and I know that you guys care about people being enrolled, but the reality is the exemptions, like maybe it will work, but like 48 jobs is just so insane. Like these modules, like all like adding more tasks to people who don't have the internet, who don't have access to like, who don't have like, like maybe literacy is hard for them. Maybe like they're just like busy. Like I had a neighbor that had domestic violence and like trying to help her get through. That's why she didn't get SNAP. Like she couldn't get it, like I've watched people not get what they needed because how were they supposed to be able to get the things they needed when their life is insane and just so stressful and so many things on top of them. And every time that I say, I promise though, like if we just do this and we do this and there's going to be an exemption for you or we can call and we can try to fight it. Like they're so burnt out, like they're so overburdened. And I just like, it's just so important that like, this is what, like, these are the people that Medicaid is for. This is the people that Medicaid can change their life. And it's, and I worry about how it becomes like it's just a way to kick people off. It's a way to say it's not an entitlement anymore. And you have to like meet certain, you have to meet other program requirements. And so it takes away the like idea that like if you're legally eligible, you deserve to get health care, and they could be eligible and just not meet this requirement and be eligible through all other means. And it's just like, I don't know, it's just like, so it's just like heartbreaking. I understand where you guys are coming from, but like it's disappointing nonetheless, and just a shock like that we're going to just move forward with this without making Congress like claw for everything that they want to do to strip away these people's health care and just like, anyway, so it's just hard. It's just hard. I just know I'm about to receive, and I'll hear from people that do get the like exemption. Like I know that those are people I know too, but like they won't understand that either. Like to them, they'll just be like, oh, it's just another thing. Like, and then like, I feel like the more that like I hear from people who get a notice about something really basic and they're afraid that notice means they don't get health care anymore. And it can be nothing that's threatening their access. And yet it's just, that's the reality of a lot of our beneficiaries. And that fear of just constantly like maybe having your health care taken away whenever your health care is like so important to so many of these people. It's just, I don't know, that's just what's so hard. And it just feels like some arbitrary just administrative burden, and it's just ironic that there's like a Department of Government Efficiency going on when we're about to just make people who are like barely getting by and doing the best they can have so much more inefficiencies in their life. And we worked so hard 7 years ago to like not let this happen. So anyways, I understand. I'm just really sad. So I just had to say that.
Thank you, Stephanie. Go ahead, Colleen.
I just wanted to thank Stephanie for saying that. Again, it's not about,
we're preaching to the choir here in this meeting, it still is important to have that on the record, and to have you say it with the passion you did, I also think is so important, because again, in some capacity, we do all recognize those underserved populations, and thank you for speaking out to them.
Yeah, and I thank you as well. Thank you, Colleen, for your comments, and Stephanie, thank you for yours as well. And I think if there are no other comments, I would like to say that I think Laura's put a few things into the chat, but Colby has drafted a two-pager that we will be releasing to lawmakers later today or by tomorrow to communicate this message. We've been working with some of them already, but they'll be receiving the official notice. We'll also be able to share that through the MAC. And so we'll share that. It's just a brief two-page overview of the waiver itself. And then we will be posting it publicly starting on Monday. And so I recognize and appreciate this is a very, very challenging time, and we need your input and your feedback as we work through this process. And so I think, Laura, if you could put both the MAC meeting, we are holding a special MAC meeting. We'll be holding 2 MAC meetings in May. One will be our budget request meeting, which is held on the 3rd Thursday of May, but we are holding a special MAC meeting for this to take your comments at that time. We are also holding another public meeting and also have our website open. So we will have a MAC meeting on Friday, May 2nd from 12:30 to 2, which will be specifically for this waiver. So it gives you a little bit of time to review it and then present your questions. We also have our email that will be open and be able to take comments as well. So we appreciate your input today. And yes, and the second hearing is on May 14th from 4 to 5. So we appreciate this. I know this was not an easy message to deliver, and appreciate your comments that you did share, and appreciate the feedback that we've received already. And we'll, obviously engage in more discussion in upcoming weeks. With that, I think those are my director report updates for today. Thanks, Rachel.
Thanks. So yeah, just reiterating that we will have language for us as of this Sunday of what's going to be in there. I'm asking MAC members to please review that. And then once you send that 2-pager, 1-pager, Jen, I can't remember how many pagers it is, to the lawmakers, could you send that to, is that something that you'd be able to send to us too, to maybe break that down?
Yes.
Great. Awesome. So
Yep.
if we, please review that ahead of the meeting so we can have that discussion and have it be robust. And I look, maybe not forward is the word, but I'm looking to reviewing the language submitted. And then any other questions or comments about this process? Just, I mean, I know a lot of people are probably shocked. So I want to, any questions that can be answered today, want to be able to answer them for folks. And again, reiterating that written public comment process as well. If, speaking during meetings isn't the best way for you to express your thoughts and concerns, and it's easier for you to do it on paper, the written public comment process is there. And you can do both if you really want to as well. No one's stopping you. Anything else? Then I'm going to take just a quick second. As most of you know, because of, not because of, but I guess kind of because of the creation of the BAC, the MAC has defaulted to less frequent meetings, still as frequently as needed by federal requirements and by the MAC bylaws. But the meeting cadence is now January, March, May, June, August, and October. So that's not monthly like it was in the past. That does not mean that we cannot decide to meet, but going forward, besides maybe emergency or ad hoc meetings or something like the work requirement public or MAC meeting at the beginning of May. If folks would like to meet in a month that we do not have a MAC meeting immediately after, so this a good example was last month in what was last month? March. Last month in March, we did not have an April meeting originally scheduled. Please, if you are wanting to have the MAC meet, and this doesn't apply to this meeting because we do have a May meeting, which is the budget presentations, please come to the MAC meeting with some agenda items that you would like to discuss during that meeting. Also during executive committee, I think we can also discuss whether there is a need for that meeting if there isn't one already scheduled for that week or that following month. Sorry, this wasn't my best presentation, I don't think, but I hope that all made sense. So just going forward, if you're a MAC member and you would like to request a meeting at a month that there isn't one, please come to that meeting with some agenda items. And then sometimes I think that as the executive committee will probably suggest having one as well. But this doesn't apply to May, nor does it apply, doesn't apply to June as well. So if you're thinking about looking forward to a July meeting, that might be needed given, what's going on federally, but just going forward, keep that in mind. But also keep in mind that we have to work towards having a certain number of members of the BAC also serve on the MAC, and that adds more meeting requirements for the BAC as well. So just something to keep in mind. That's not super relevant right now, but will become relevant going on. And also, I believe you guys are still recruiting for members of the BAC. That's the Beneficiary Advisory Council, I think. So if you know anyone that would be interested in serving on the BAC and also the MAC as well, given that we have to start, fixing that number and making sure that it's balanced correctly to give beneficiaries more of a voice. Just keep that in mind as you talk to folks and talk to people on the program or that would be able to serve on the BAC. Any questions there? And as a reminder, there's nothing stopping us from calling ad hoc meetings if we need to. And that might be something that we need to start doing more going forward, again, given all these changes. And then last thing is committee member updates. So I will open the floor to anyone with any committee member updates. Hearing none, I just want to thank everyone for their input today. It's nothing's been easy in the Medicaid sphere, and I really appreciate all of you showing up and submitting that, like, your opinions and concerns. It does mean a lot. Well, going forward, we'll see you all on May 2nd at 12:30 to 2. And also reminder that budget presentations will be done on May. Oh, I can't remember the date of that one. Does someone want to throw me an assist on this one? Hold on. Oh, May 15th from 4 to 6 p.m. Will be the budget presentations meeting. I will actually be on a flight, so Dr. Britton will take over as the chair. If you have those budget requests, please submit those there. What is the actual deadline for that? Is that a week before?
I'm waiting for Sharon to answer here. Sharon, are you taking requests up to a week before?
Yes. Can you guys hear me now?
Yes.
Okay, perfect. Thank you. Sorry, I was speaking and didn't realize I didn't come off mute because I had to log in on my phone. So yes, the presentations are due by Tuesday, May 6th to me. Still taking presenters. If you would like to present, please email me. And yeah, so May 6th is when the presentation materials are due. Thank you.
Thank you, Sharon. And then with that, I think we are done for the day. Please enjoy the rest of your days and enjoy your upcoming weekends. Bye.